Hey guys, welcome to Quickfire Medicine, your place for fast, high-yield content for medical students and junior doctors. Today's topic is on how to classify pituitary tumours. The pituitary gland is located at the base of the skull within a hollow space called the sella turcica, just inferior to the hypothalamus. Pituitary tumours are common, representing 10 to 25% of all intracranial neoplasms. They're made of predominantly glandular tissue and are mostly benign, giving them the name adenoma. You can classify pituitary tumours in two main ways, first by their size and second by the hormone that they produce. Tumours less than 1 cm in size are called microadenomas and are often incidentally found on neuroimaging, being so-called incidentalomas. Tumours greater than 1 cm are known as macroadenomas, and these tumours are much more likely to cause symptoms through their mass effect on surrounding structures, particularly with suprasellar extension that causes compression of the optic chiasm that leads to a bitemporal hemianopia visual field defect. The second way of classifying pituitary tumours is by their hormonal effects, but first a quick reminder on pituitary hormones. The anterior pituitary gland has cell groups that produce several hormones, whose release is under control by hypothalamic releasing hormones that travel down the pituitary stalk and stimulate release of these hormones. An example of this is thyroid releasing hormone, or TRH, which is released from the hypothalamus, travels down the pituitary stalk to the anterior pituitary gland, where it stimulates thyroid stimulating hormone, or TSH, to be released. The exception to this rule is the hormone prolactin, whose pituitary release is instead inhibited by dopamine that comes from the hypothalamus. Tumours that affect specific cell groups cause release of that specific hormone and are called functioning tumours. The most common example of a functioning tumour is prolactinomas, which produce the hormone prolactin and therefore cause features of hyperprolactinemia. Acidophil tumours release growth hormone and cause the condition acromegaly. Best to remember A for acidophil and acromegaly. Basophil tumours instead release ACTH and cause Cushing's syndrome, more specifically termed Cushing's disease. These tumours can also cause globally reduced function of the rest of the pituitary gland, which is known as Hypopituitarism. This occurs by the tumour compressing the pituitary stalk, stopping the travel of releasing hormones and dopamine from the hypothalamus down into the pituitary gland. Therefore, in Hypopituitarism, all of the pituitary hormones will reduce, apart from prolactin, which will increase because it's under inhibitory control from dopamine, as well as whichever hormones being produced by the tumour. In fact, up to 50% of tumours don't actually produce any hormones, and these are known as non-functioning tumours, or chromophobes. The best way to remember these is that chromophobes are phobic to producing hormones. Don't forget, however, that they'll still have some hormonal effects by way of hypopituitarism that occurs from compression of the pituitary stalk. Last but not least, Craniopharyngiomas are a slightly different type of tumour of the pituitary stalk that originates from Rathke's embryonic pouch and usually occurs in childhood. Whilst classic pituitary adenomas compress the optic chiasm from below, reflecting as a predominantly superior bitemporal hemianopia, Craniopharyngiomas compress the chiasm from above, causing a predominantly inferior bitemporal hemianopia. So that's what you need to know about pituitary tumour classification. If you enjoyed this video, please hit that like button, comment down below, and make sure you subscribe to my channel. Thanks so much for watching, and see you next time.